Next up, we're going to have a talk on respiratory, and we have Eric Dyke, who is a retired RCMP officer since 2007. He was paralyzed with a T2 spinal cord injury from a fall in 2017. After his SCI rehab at the Glen Rose Hospital, he undertook further rehab at the REU Paralysis Center, REU Paralysis Recovery Center in Edmonton. He's also had an implantation of 2 spinal stimulators and is currently enrolled in an FES study at the U of A. Eric travels extensively throughout the year and is an avid swimmer. He lives independently with his partner on an acreage near St. Albert and drives to California every winter. A lucky guy. Although he has required hospital admissions subsequent to his SCI for a heart complication and more recently for a fractured femur, he has not been admitted for any chest infections thanks to adhering to his neuropulmonary rehab management strategies. We also have Dr. Janice Richmond-Eisenstat. Dr. Janice Richmond-Eisenstat is an associate clinical professor in the Pulmonary Division, Department of Medicine at the University of Alberta. After completing her postgrad medical training in pulmonary medicine, critical care medicine, and clinical pharmacology in Toronto, she undertook postdoctoral research fellowships at the University of California in San Francisco. In 1999, she was recruited to the University of Manitoba as a clinician scientist at the Manitoba Institute of Cell Biology. She has been practicing pulmonary rehab medicine since 2007, focusing on complex respiratory disease. She moved to Edmonton in 2011 and now specializes in neuropulmonary rehab medicine, chronic ventilation, and palliative respiratory care. She works out of the Glen Rose Rehab Hospital in the SCI General Neuro Rehab Program and provides complex respiratory consultative services to acute care, critical care, home care, and long-term care. Welcome. Thanks for coming today.
Okay, hello everybody, and thank you for the opportunity to speak today, and especially to Dr. Janice for entrusting me with talking about my lived experience as a spinal cord injury individual. I received my spinal cord injury while snowbirding in Palm Springs, California in 2017 as a result from falling just 7 feet from a ladder in my driveway, injuring my spinal cord at the thoracic level 2. I was taken to a trauma hospital by ambulance where I was stabilized with fusion surgery from the T1 to T6 vertebrae. I was categorized as a T2 complete injury, meaning I was paralyzed from the chest down with no motor movement, no sensation from below my injury level, and very little hope of ever regaining function in the future. When I woke up from surgery, not only did I realize I was paralyzed, I immediately realized I was having difficulty breathing. However, was not placed on a ventilator. Day after day, I was continually failing a simple swallow test with crackers. I wasn't able to cough up phlegm. I wasn't able to sneeze or even have the power to blow my nose. This was all very frightening to me as I was immediately impeded with these issues. During my hospital stay in Palm Springs, I was not given any equipment to help me with my breathing, such as an LVR, nor was I given any chest physio. Oops, this was like it. More than being told I would never walk again, I had major fears about breathing day in and day out in the context of my SCI. It kept me awake in fear of choking on my own phlegm. Although I was spared from going on a ventilator, it did cause me great trauma and a great deal of anxiety. During my stay in the trauma center, I was having to be suctioned several times a day with a catheter down my throat, which was unbearably uncomfortable and scary for me. Had I only known then what I know now, and that my quality of life would greatly improve with many of my fears being just a distant nightmare. I stayed approximately 2 weeks in the trauma center before being airlifted back to the ICU unit at the University of Alberta Hospital. During my stay at the U of A hospital, I was not given any breathing supports, breathing exercises, or any type of rehabilitation. I was continually getting suctioned and was choking on food, and often required both manual cough assist and mechanical cough assist. I was not given much encouragement for a good quality of life, and in fact, one respiratory physician told me to get used to the ICU and the emergency ward, as I will be back there several times a year if I got a cold or a chest infection, and I would have constant pneumonia issues, which was just putting more fear and anxiety into my life after his comment. About a month later, I was transferred to the Glen Rose Rehab Hospital and placed under the care of a physiatrist and Dr. Janice, who assured me I would not be ending up in ICU nor the ER department. She would later teach me and give me the tools to help my breathing and to be able to clear my throat on my own. This reassurance in itself relieved much of my anxiety and fears and later proved to greatly improve my quality of life. I was now well on the way to once again having a good quality of life and less fearful of the future.
Thank you very much, Eric. I'm going to ask people, I'm going to share my screen, and I'm going to ask people to make sure that the view is side by side. But first, I want to give a very quick review of the respiratory mechanics. So if my arms are the muscles innervated by the spine, the nerves from the spine, and this art project, crafts project, are the lungs, and these holes are the gas exchanging air sacs or alveoli where oxygen and carbon dioxide are exchanged. Here's what happens. Our breathing muscles inhale, exhalation is passive, but coughing is active. That's the summary. So I'm going to share my screen now. And I'm going to focus on respiratory management post-acute care. So the impact of breathing by a spinal cord injury very much depends on the level of the spinal cord injury. It also depends on what was going on with the respiratory status. What was the respiratory status before the injury? Did someone have asthma or COPD or asbestos exposure and plaques, interstitial lung disease, prior surgery, prior problems, mechanical problems with their breathing? Also, and were they on any medications for their breathing? Did they have a history of frequent chest infections? Also, what else happened at the time of the injury and initial management? So in other words, at the time of the spinal cord injury, did people also have damage to their rib cage? Did they have bruises to their, actual bruising to their lung parenchyma? Was their heart traumatized? What else was going on? And how were they managed? Did they need to be intubated to help with their breathing? Were they able to get off of breathing support by extubation, removal of an endotracheal tube, or did they need to have a temporary tracheostomy? And then during that initial management, were they having recurrent chest infections? Were they having pneumonias, hospital-acquired or ventilator-associated pneumonias? Were they getting pleural effusions? Did they go into heart disease? All of this impacts how the spinal cord injury affects the breathing. So certainly, if one of the most important things to remember is that C345 keeps the diaphragm alive, and the most important breathing muscle is the diaphragm. The other muscles that assist inspiration, breathing in, are the scalenes supplied by C2 to C7. Then there are these accessory muscles of inspiration and the muscles of expiration. And it's these muscles of expiration that are most important for cough. So C2, the accessory nerves and C2, C3 support the sternocleidomastoid. The intercostal muscles are supported by T1 to T11. And the abdominal muscles, especially the transversus abdominis, are supported by T7 to L1. And it's these abdominal muscles that are really important for cough. So if someone has a C1 to C2 level of injury, they will require permanent invasive ventilation, but they may be a candidate for diaphragm pacing, where there are stimulators, electrical stimulators implanted in that very thin diaphragm, it's like paper thin, that could allow for potential ventilator-free breathing. If the level is C3 to C4, they could have possible independent breathing, but they will definitely need breathing support during sleep. Because all of us, when we sleep, we breathe less, but how much less will determine whether it's sufficient to support oxygenation, exhaling carbon dioxide. And if we don't exhale sufficient carbon dioxide, the acid-base balance changes and we could become acidotic and be in frank respiratory failure. C5 level injury, we may or may not have ability to have independent breathing, especially at night, but we will definitely need, like the higher levels, long-term support with airway clearance, range of motion for the chest wall, and support for coughing. With C6 to C8 level of injury, independent breathing is quite likely, but again, we'll still need support for the range of motion, exercise for the chest wall, to keep a compliant chest wall, and assistance with coughing. T12, injuries at T12 or lumbar spine, the innervation to the abdominal muscles is preserved, so there should be no respiratory compromise, and the person should have an effective cough. So what happens, what we watch for after a spinal cord injury is difficulty with coughing, clearing mucus. People describe having difficulty taking a deep breath or not being able to breathe, or as Eric described, not being able to sneeze or blow their nose. If the swallow is also affected, then choking can occur. Patients can be in frank respiratory failure. People could have sleep disordered breathing where they can breathe adequately when they're awake, but they've lost the reserve to support breathing during sleep. They could have pneumonia, and with impaired cough, pneumonia is quite likely. And if it's not even pneumonia, it could just be atelectasis from not fully opening up the lungs. And atelectasis is collapse of these gas exchanging air sacs. And yes, the oxygen level could go down, and people could be given oxygen, but oxygen isn't going to help open up those atelectatic airways. And when there's atelectasis, there's the natural phlegm production or mucus production of the lungs accumulates in these atelectatic airways, and is just a candy store for the development of pneumonia. Long-term effects can be chronic respiratory failure with recurrent pneumonia. People can get bronchiectasis, which is abnormal dilatation of those airways that lead to the gas exchanging air sacs or alveoli. And those abnormal airways produce an excessive amount of mucus, which if you have that level of spinal cord injury where you have an impaired cough, tend to accumulate and then just perpetuate that cycle of recurrent pneumonias. The other thing is, if you're not doing those range of motion exercise for the chest wall, you can get a frozen chest because if you don't stretch out a joint or the muscles, the joint and the muscles get stiffer and stiffer, and you end up with a completely scarred down chest wall. The other thing that we have to watch out for is post-operative respiratory failure. So it's not uncommon for people to be just, getting along, just making it with whatever respiratory mechanics they have left. But as soon as they're tipped over the edge, either by a chest infection or by a minor surgical procedure, that's the first time they might present with respiratory failure. So when the respiratory therapist and I are assessing someone with a spinal cord injury, we want to know the basics. Can you talk? Can you eat? Can you swallow? Can you cough? Can you breathe? And if you can breathe while you're awake, can you breathe during your sleep? Those are the critical things we need to know. to help us manage that key set of daily functional activities that we take for granted, we also need to know, do you smoke? What other respiratory disease do you have? Are you on an inhaler? Is your respiratory mechanics such that you can no longer use your inhalers the same way and ensure that the medication is getting deep down to where it needs to work? Did you have other injuries to your chest that may impact how we do airway clearance or how we help you breathe? What other diseases or injuries do you have? Do you have heart disease? Do you have renal failure? And what's your vaccine status in terms, because that is key to preventing further complications of breathing. I also need to know, do you have any nasal symptoms and what is your hand-arm function like? And I need to know that for so that I can best make recommendations on how to use the tools, tips, tricks, techniques that we teach our patients in neuropulmonary rehab. What studies do we do? Well, I need to know if you're ventilating. Are you blowing off your carbon dioxide? We can assess that non-invasively with measuring your end-tidal spot check of your end-tidal CO2, or we can do a more invasive arterial blood gas. Also want to know what your oxygenation is. Again, non-invasively, we can check your saturation with the pulse oximeter, the gadget that goes on the finger, or more invasively with arterial blood gas. I want to know what your respiratory muscle power is like. How strong is your inhaling muscles and how strong are your exhaling muscles? By measuring your MIPS and MEPS, your maximum inspiratory pressures and maximum expiratory pressure. Or we can measure your negative inspiratory force just with a sniff. Very importantly, I want to know your cough strength. How strong is your cough? And that's simply measured with a peak flow meter that we use for monitoring our asthmatics, except instead of asking for a blow, we ask for a cough. And we're looking for a cough that's stronger than 360 liters per minute. If that's peak cough flow is 270 or less, you'll have ineffective airway clearance and you're high risk for choking spells that lead to respiratory failure or retained secretions that lead to pneumonia. I want to know how big a breath you can take and how fast can you get that air out? What is your vital capacity? And do you have any airflow obstruction? And to do this, we just use simple spirometry with a spirometer. And I want to know what your upright spirometry is and your supine, lying down spirometry. Normally, with higher spinal cord injuries in the cervical range and the upper thoracic, typically your vital capacity when laying down is higher than when sitting up. Whereas if in the absence of any spinal cord injury, your vital capacity should go down just a bit when you're supine as opposed to increasing. However, if you also have damaged or injury to your diaphragm, a person with a cervical spine injury or thoracic spine injury, their supine vital capacity will decrease instead of increase. So from all these results, I get a good idea of how you're breathing during the day. But I also want to know, I need to know, just because you breathed well during the day, you might not be breathing well at night. So everyone gets screened with overnight oximetry at the Glenrose, or we can do a level 3 sleep study where we're measuring pulse oximetry, a finger probe for measuring your saturation and heart rate, prongs in the nose to measure flow, and a band around the chest to measure chest wall movement. And these are great screening tools for sleep disordered breathing. Sleep apnea, as an obstructive sleep apnea it's much more common in people with spinal cord injury than the general population. A level 1 study with all the bells and whistles where people have to sleep overnight at a hospital is not possible for the population that I look after because all their other care needs cannot be accommodated in the sleep lab at Edmonton. The other thing I need to know is whether what your swallow is like, because it could be that you're now multitasking, having to coordinate breathing and swallowing. And if you have a weak cough and you have poor swallow, you're at high risk for aspiration, choking, and aspiration pneumonia, which could lead to acute respiratory failure. So what can we do for this? Well, if people have chest wall restriction or ineffective airway clearance, my favorite low-tech, inexpensive gadget is this lung volume recruitment apparatus, which consists of an ambu bag, like for resuscitation, except this is not used for resuscitation because there's a one-way valve. There's tubing and then a mouthpiece or a mask and nose clips if needed to make sure that the air gets pumped into the lungs and not out the nose. And so lung volume recruitment, first and foremost, is for the range of motion exercise for the chest wall. So we pump air in as the method to exert an external force to stretch the chest wall and open the lungs. The effect lasts for 60 to 90 minutes, and this is why we recommend that LVR is done before mealtime and at bedtime. And any other time you want a louder voice, you want to blow your nose, you're going to exercise, you desaturate, or you have to cough and clear, or you just want a bigger breath. I do strongly advise this for before exercise. And also in that vein, following from our previous talk, it's great to do just before sex. If someone's doing lung volume recruitment isn't enough to enable a stronger cough where the peak cough flow is 360 or greater, or at least 270 or greater, then we need to teach people how to do a self-manually assisted cough, or teach their caregivers how to do a manually assisted cough. You may be familiar with the Heimlich maneuver. So it's the same idea, but instead of going in the upper abdomen, it can be done from the side of the abdomen or the lower rib cage. But if doing lung volume recruitment and a manually assisted cough isn't sufficient to get an effective cough, then we need a mechanical inexsufflator. People commonly refer to this as a cough assist, but the Respironics cough assist machine is no longer on the market as of June 2022. And so it's the Sinclair that's now on the market, made by Baxter. There's another machine made by Air Liquide, but it's not as effective in attaining maximum insufflation capacity and peak cough flows. Now, this is my favorite high-tech, but very expensive gadget. So an LVR apparatus costs about $65. The Sinclair costs between $6,000 and $8,000. However, this is a fantastic piece of equipment for achieving an effective cough that clears the airways, gets our patients out of trouble, keeps them gets them over a cold, gets them over pneumonia, helps prevent admission to hospital. And if they do get to a hospital, gets them out of a hospital admission, also helps keep them out of ICU. Or if they do get to ICU, it gets them out of ICU faster. It also prevents intubation and mechanical ventilation or invasive airway management strategies. In addition to helping people cough and clear with these gadgets, there are other gadgets that facilitate or methods to give chest percussion, such as just manual chest percussion, or using the mechanical inexsufflator with an oscillation feature, which gives internal chest physio. And there are medications that can be used to thin the airway secretions by nebulizing medications, providing that the humidity to make for a nice thin secretions, which are easier to cough up, but also it emphasizes the point to make sure you're well hydrated. That also helps thin the secretions. Another important neuropulmonary management strategy is strengthening the respiratory muscles that do work. And as long as it's C3 level or below, that diaphragm should be working. So the thinking these days is that we should be doing everything possible to strengthen existing muscles. So that could include this respiratory muscle trainer, which is well known among the exercise buffs and the professional athletes, to strengthen those respiratory muscles to improve endurance. Interestingly, when we use this gadget for respiratory muscle training, it also cross-trains the muscles of speech and swallow, which could also facilitate helping people have less risk of choking. But there are simpler, there are other strategies that can be used, such as just blowing bubbles. You know, that thing that our parents always, told us, don't blow bubbles. Well, blowing bubbles can strengthen the breathing muscles, the expiratory muscles, or do abdominal weightlifting, where you put a weight on the abdomen and just exercise. You can ask the physiotherapist to gauge what weight and the frequency of abdominal weightlifting. Now, for people with whose diaphragm no longer works because the spinal cord injury is so high, there's the option for diaphragm pacing. I've heard that there are very strict requirements for this option for diaphragm pacing. Not everyone's a candidate. Other things that are experimental and in a hot research topic is, can functional electrical stimulation, for example, to the abdominal muscles, strengthen the respiratory muscles? And then other interventions that are being used in spinal cord injuries, such as spine stimulators, implanted spine stimulators. What is the impact of these stimulators on respiratory muscle strength, lung volume, and the ability to cough and clear? Now, for people who have sleep disordered breathing, in other words, they don't breathe sufficiently or effectively during the night, what can we do about this? Well, there's CPAP, or continuous positive airway pressure, for obstructive sleep apnea. If the impact is the required treatment is just to keep the airway open. If the person is taking too small a breath or just doesn't have the muscle power, then they might actually need non-invasive ventilation with a BiPAP machine. And the gadget looks exactly the same, whether the CPAP and BiPAP machine look exactly the same, but they are functionally very different. There's also about a $3,000 to $4,000 difference in cost. If we don't treat sleep disordered breathing, what happens? Well, our patients tell us, and we see, they have low mood, depression, difficulty coping, increased muscle spasms, poor wound healing, increased propensity for chest infections, and a higher risk of going into severe respiratory failure if it continues and it's ineffective. And the long-term effect is chronic respiratory failure. If someone has chronic respiratory failure, then they may end up needing 24/7 respiratory support, and that can be achieved with non-invasive ventilation with BiPAP for sleep, or BiPAP during the day through a nasal interface that allows for eating and talking, or through mouthpiece ventilation, where there is a tube with a mouthpiece that's attached to a ventilator, and the person can just breathe by taking a breath in when they want, just like when you're thirsty, you take a sip. The alternative to non-invasive ventilation is invasive ventilation. And my hope is that the majority of people should be managed with non-invasive airway management strategies. Other critical management strategies include smoking cessation and prevention of respiratory complications, like being proactive and preemptive. Get your vaccines. Don't allow people to come visit you if they're sick. Make sure you're avoiding smoking environments, whether it's secondhand, thirdhand smoke, or making sure you know what to do when the smoke from fires is overwhelming. The other thing that's critical to neuropulmonary rehab is education. Know how to manage your symptoms of cough, breathlessness, difficulty swallowing, poor sleep. Make sure you know how to recognize how to prevent an infection and what a chest infection feels like and looks like, so that you hop on it and don't wait for a complication. Because if you wait to see your family doctor, that may not be sufficient time to treat the infection, and you may very well end up in emerge, acute care, or even the ICU. Know what to do if you inadvertently choke on something, something goes the wrong way, or you get mucus plugging and you're choking. Know how to recognize the symptoms of sleep disordered breathing and respiratory failure, so that as soon as you have these symptoms, you get attention to these symptoms and you get onto treatment. Know who your supports are and contact them when needed. So I like my patients whose breathing is impacted to have a home care respiratory therapist. They are my right hand, just like the Glenrose RTs are my left hand. Know who your primary care practitioner is and work with them so that they are educated on your needs, and make sure you know who your spinal cord injury clinic nurse coordinator is. Part of this education, it's critical to understand your breathing and your breathing needs, because you need to be able you need to know that if you go to the ER or the hospital, bring your equipment. Don't assume they're going to know what to do or take or supply with you. No, if you are on home CPAP or BiPAP, they're not going to give it to you in emerge or in acute care. Bring it in. Notify or have someone notify your home care RT, because they become a crucial resource for the hospital RT to take better care of you. And if you're going for surgery, know your neuropulmonary status, because it may be that you're okay when you're at home, but if you undergo conscious sedation or general anesthetic, you might be in deep trouble. So make sure you know the status and get the necessary pre-operative assessments, and maybe you need an ICU bed on hold to mitigate respiratory complications or respiratory failure post-op. And again, make sure you bring your respiratory equipment with you. So overall, my goal in these strategies is to maximize quality of life, for you to be proactive and preemptive in managing respiratory symptoms, and to prevent or at least minimize respiratory complications. Canvent Ottawa has an excellent website on these, all these neuropulmonary strategies. And in the limited time that we have left, I'd like to turn over to Eric and ask him a few questions. Eric, can you quickly tell us what happened when you finally got to Glenrose?
Yeah, so when I arrived at the Glenrose Hospital, I had a consult with Dr. Janice and had extensive respiratory testing. I was immediately given an LVR as well as breathing exercises, and I was given a sleep study. And within a few days, I was assessed and fitted with a CPAP machine. I was given reassurance and provided with an action plan by Dr. Janice. And during my stay, I was routinely visited by RTT professionals, and continuing education was provided with the LVR, as well as continual monitoring of my breathing. I only wish that at the beginning of my injury, I was provided with the LVR and an action plan, as it would have saved several months of suctioning and worrying and anxiety.
I'm going to skip the next question and go to the question about what do you do when you get sick?
Oh, just 1 second for I just have computer malfunction. Yeah, so for my lung health, and now that I'm home and after 4 months stay in the rehab hospital in 2017, I received all the available vaccines and continue to use infection control strategies with using my LVR 4 to 6 times daily. I sleep with a CPAP machine, and I'm proactive and preemptive. I have a home care RTT that sees me on a regular basis in my home, as well as yearly follow-ups with you, Dr. Janice. So when I'm sick, I know who to contact. I now have a team of medical professions, and I carry this list with me whenever I go to the hospital. One of my biggest fears was getting COVID, which I did end up getting last year, and again testing positive for today. With the help of Dr. Janice, she was able to keep me from landing in the ER. I did not require acute care or ICU, and my greatest fears were now relieved. I survived COVID through breathing education and the use of my LVR and keeping up with my vaccinations. I've had 0 hospitalizations for chest infections, just like Dr. Janice had predicted years earlier when we met in 2017.
Yes, I'm a very good palm reader and tea leaf reader. And can you tell me how many, have you been to hospital and what was your experience like?
Yeah, so when I go to the hospital, I find the acute care teams do not know much about spinal cord injury. I want and need them to know about my breathing in the context of my SCI and that my LVR and CPAP are not optional. My recent hospital stay as a result of a broken femur resulted in me being placed on a surgical ward. I found the nurses had very little experience with spinal cord injury with respect to breathing, being turned and repositioned in bed. I was often placed on wrinkled sheets causing pressure wounds and automatic dyslexia at times. One night I woke up at about 4:30 in the morning, obviously from a sleep apnea event. I found I had no call bell, no LVR beside me. My broken leg was on the floor as the bed rail was left down. And even more startling, I didn't have my CPAP on all night, nor my oxygen flowing. Clearly, I wasn't turned, repositioned, or checked on from the time I fell asleep until I woke up in a panic in the early morning hours. Whenever I attend a hospital, I bring my own alternating pressure air mattress, my LVR, my CPAP, and Dr. Janice's cell phone number. During my stay, I would try to inform the nurses of SCI websites for SCI specific care. I would continually bring up AD, autonomic dyslexia, which very few nurses even heard of, or the team, or the seriousness of the events. The impact of the learned strategies I have now has a huge impact on my quality of life. By following these strategies, my fears of breathing, choking, swallowing, coughing, sneezing, and phlegm issues are greatly relieved. I only wish I was taught these strategies while I was in acute care. It was only after I was sent to the Glenrose I realized I could live a full life again. After the Glenrose, and to continue improving my quality of life, I traveled out of the province for an ostomy and later received a suprapubic catheter, which even further improved my life, which has now allowed me to continue to travel. I now do all the things I did before my injury, but from a wheelchair. I now feel empowered by being given the tools to live my best life.
Thank you. Thank you, Eric. So I think we've run out of time, but I'm happy. I've left my email address and I'm happy to answer any questions, as is Eric, if there is any time for questions.